Let's talk about skin through the lifespan. Starting with infancy, newborns are born with a casein-rich coating called vernix caseosa, oftentimes just called vernix for short. Casein is like a milk protein, it's similar to a milk protein and has a waxy consistency, much like um, the ceramides that are secreted in the granular layer of your skin, and sort of like an earwax kind of a molecular arrangement. And this is covering their skin to help protect them against the watery environment of the womb. It helps, since their skin is so thin and not fully developed yet, it's not really very keratinized yet, it's not itself able to repel the liquids from the, or not, it's not capable of keeping the liquid of the amniotic sac out. If you didn't have this casein covering, this sort of waxy coating to your skin, they would be absorbing more amniotic fluid than you would want. That vernix caseosa is produced on sebaceous glands, which are abundant in newborns. They start to peter off a little bit as the child ages. And this protects the infant skin in utero, as I mentioned. They also often have little white spots on their body called milia. Those are just sort of like little transient clogged pores, not really like acne exactly, but they're a product of the sebaceous glands being so active. And they're often covered in what's called lanugo, which is body hair, and it's that thin, wispy hair. It's very similar to the vellus hair that we have all over our body, only on babies it tends to be quite a bit thicker, particularly if the baby's born a little on the early side. Not premature exactly, but in a 40-week gestational period, if the baby's born at 37 weeks, say, or 38, close to full term, but not 100%, they'll still retain more of that lanugo than they would if they made it to 40 or 41 weeks, oftentimes. Of course, there's a huge amount of variation in this. And that lanugo can really go a long way towards helping the baby thermoregulate in its first days. Newborns don't have very much fat. They have very thin skin. So they have extra things on that help keep them warm. So they have brown fat, remember? Brown adipose tissue, which is rich in mitochondria and can help them generate heat. And they also have this layer of lanugo over their body that helps keep them a little bit warmer. As the infant ages into childhood, the skin becomes thicker and more richly keratinized. The number of sweat glands that you have is actually genetically predetermined. So if the child's growing up, the sebaceous glands just sort of get spread out as the child ages and grows. And the number of sweat glands that the child has are genetically determined. So how many sweat glands I have, you have, whoever has, is set from birth. But how active they are is not set from birth, and that's influenced environmentally. I was raised in like in my infant years, in the first couple of years of my life, because this is determined in the first 2 or so years of life. I was raised in central Pennsylvania. It doesn't get that hot in the summer. It gets very, very cold in the winter. I don't really sweat that easily. When it starts to get hot, I just wilt. I don't deal very well with it. My body doesn't have very efficient cooling mechanisms because I have X number of sweat glands and they were never sort of trained to be very active. If instead I were raised in, say, the Amazon jungle, where it's very, very hot and it stays warm year round, and I spent the first couple years of my life there, my sweat glands would have been sort of trained to be more active, to more efficiently cool me off, and I wouldn't suffer quite so much in the summertime. As the child grows up into adolescence, the overall consistency of the skin becomes more like adult skin. It's thicker, it's more keratinized, and you start to have certain glands turning on that will persist through adulthood, particularly in the early sexually mature stages of adult life. The production of sex hormones is what causes most of the notorious changes of adolescent skin in particular. You have an increased activity of sebaceous glands, both your regular oil on your face kind of sebaceous glands that you associate with greasy skin and acne, as well as those hormonally controlled ones in the groin, in the armpit, that start to turn on in abundance, and the adolescent's microbiome will change in those regions accordingly to match the new environment. When you have the turning on of these sebaceous glands, particularly in places like your face where you have relatively delicate skin and a lot of these sebaceous glands, remember that sebaceous glands secrete by holocrine secretion. So they fill themselves up with food, with oil, and then they just kind of explode. And when they explode into the lumen of the gland, all its cellular debris goes along with it, which turns out to be really great bacteria food. You have oil, you have a warm, dark place, you have lots and lots of loose proteins and sugars and fatty acids and stuff. Great bacteria food. And when these oil glands turn on, and they kind of turn on in a big surge and stay on a little extra much for a long time before they dial back in your early adulthood, that turns out to be a good environment for acne bacteria to grow. Again, you have activation of your apocrine glands. Those are those hormonally turned on ones in your armpits and groin. Your hair becomes thicker and coarser and more abundant. So that includes the hair on your head, remember? So if you think about how soft and wispy children's hair tends to be, it gets coarser as they get older. It slowly gets a little more textured and coarser throughout childhood, but once the child becomes an adolescent, the texture does tend to change a little bit more quickly than they did in the previous years. Particularly for people who have a surge of testosterone in genetic males, you have a growth of hair across the body more abundantly and thicker. So not just hair on your head getting coarser and thicker, growing pubic hair, growing axillary hair, which both sexes do, but also you have this extra growth of leg hair, chest hair, arm hair, things like that, facial hair. The pigmentation in some of those areas where you have an activation of apocrine glands can also change. You'll have a turning on of melanocytes in those regions, groin, armpits, and they're generally around those secondary sexual features. So women can also have an additional pigmentation around their breasts too. Sebaceous gland activity slows down after puberty, but some other changes are permanent. So when you go through puberty, you grow pubic hair, but it's not like it all falls out when you're 25, right? It sticks around for the remainder of your adulthood. Now, as you grow into older age, some of these pubescence activated changes will peter out or go away. Pubic hair will thin, your axillary hair will thin, your sebaceous glands slow down an awful lot, so that your skin tends to be on the drier side as you get older. But more or less, once these things turn on, they don't really turn the whole way off. They might peter out, but they don't really go away mostly. Pregnancy and adulthood can create some of these changes, some permanent, some not. You can have changes in pigmentation. You can have changes in your sebaceous gland activity. You can have changes in your apocrine gland activity during pregnancy. Sometimes those will stick around after you're pregnant. Your hair will often grow in thicker across your body when you're pregnant. And sometimes it goes back to normal after the pregnancy. And there's not a ton of data about any of this. There's not a ton of really good objective data around these types of changes during pregnancy, because you'd have to do experiments on pregnant women, and nobody is going to do that. So we have these sort of accumulations of information that we've gathered, and hope that the correlations that we come to are sound. A lot of women will report that it's like the thicker hair sticks around for a long time after they've had their baby, or the pigmentation, like women will sometimes experience a darkened, like a pigmentation line down the middle of their stomach, or pigmentation changes around their breasts that persist long after their baby's born. And other women will tell you that it goes away as soon as the baby's out, and their hair falls out and their skin dries up, and all kinds of changes. It can be very, very, very variable. And there's not a lot of good data to suggest how you might end up if you were pregnant, how it would go for you. Let's talk a little bit about acne. That's sort of the hallmark skin change that we think about in changes in adolescent skin. This does tend to persist in most people to some degree into adulthood. In many people in adulthood, it'll scale back from how it was when you were an adolescent, but it usually never completely goes away. You retain at least a propensity towards some whiteheads in certain regions of your face or your skin, blackheads, occasionally get acne, particularly women around the week or so leading up to their period tend to be more prone to hormonally induced acne. It can really persist throughout your lifespan and, until your sebaceous glands really start to peter out towards old age. This acne happens when hair follicles clogged with dead skin cells or skin component become clogged with oil as well as dead skin cells and skin components. Remember, holocrine secretion is going to release all the contents of the cell into that lumen, which is great bacteria food. When you have a surge in the growth of bacteria in and around those hair follicles, around those sebaceous glands, it's going to cause a local inflammatory process. Your body's going to respond with white blood cells and inflammation. Depending on what's going on around that hair follicle at the time can determine what that is going to look like. So over here you can see an example of, or an illustration of different types of acne. Up here you see illustrations, or so you see photographs, but frankly you're more familiar with that than the bottom one. We all are, right? When you have all that keratin, right, because these skin cells or these glands are going to have a lot of keratin in and around them. When you have a blockage of keratin and oil exposed to the air, you're going to form blackheads. So that's right here and right up here. When the keratin and the oil meet the oxygen in the air, you have a pigmentation change, basically. It's almost like how iron, when it rusts, turns an orange color when it's exposed to the oxygen in the air. It's a similar type of color reaction. And so that dark color on the surface of your blackhead is the reaction with the air around it. If you were to extract a blackhead, which you are not supposed to do, I know we all do, but you're not supposed to do, you would find that the deeper layers underneath that black surface is white. If that blackhead were not open to the air, but instead had a thin layer of skin over it, which it can, depending on where the inflammation starts to grow out, then that's what a whitehead is. So you can sort of see the white nature underneath of the clog underneath a blackhead because there's a thin layer of skin over it that's keeping it from being exposed to air. But fundamentally, in practice, it's really the same type of thing. If you have the keratin and oil packed in and they sort of form a blockage, not just under the skin, but there's enough of a density that it forms its own blockage, that's when you start getting regular pimples. They can range anywhere from mild papules to deep cysts and nodules, depending on how much of your skin, how many layers of your skin is involved, and whether or not there's rupturing of the follicle. So again, you have a backup of oil, sebum, which encourages bacterial growth. It prompts an immune response, which creates inflammation. That creates redness and tenderness. If you just sort of have that much involved and nothing else happens, where it's just a clog and then your immune system comes and then eventually it all peters out when the immune system takes care of the clog, that's a papule, a regular old garden variety pimple, as we would call it. You may or may not have a little bit of a whitehead to it, where you have a thin layer of skin, but you can see the pus formed by your immune system taking care of that infection underneath. Whether or not you see that white spot at the surface of the pimple doesn't tell you whether it's a papule or a pustule or a cyst or nodule. It's how deeply involved this becomes. If that inflammation and that infection gets sufficiently bad that you have a break in the wall, so you can see that there's a bit more involvement here, you'll have a pustule. So hang on, sorry, let me see. Get rid of that, and then this should say pustule. I apologize. You'll have quite a bit more pus in that area because frankly there's just more open space now to fill with that. There will be a lot more redness, a lot more inflammation, you have more tissue damage, it's a more involved kind of a wound. When you have a break in the follicle wall that dips down into the dermis, this is where you have a nodule. Nodule is the modern term. In the past, we used to call this a cyst and refer to this type of people who are prone to this type of acne as cystic acne. Now, anybody can get the occasional cyst, but just because you get occasional cysts does not mean that you suffer from nodular or cystic acne as a general rule. Everyone will get it occasionally. Some people are much more prone to this for reasons that are incompletely understood, but it's thought that the aspects of the hair follicle underneath are thinner, frankly, and more breakable than in some people than others. And when you have a thinner barrier down there, the path of least resistance for the infection isn't necessarily up this way, but it's down this way. And so you can break deeper down. Now, when that happens, so let's keep drawing this over here. Here's your skin. And let's say you have another pore right here. If you have a breakage in this wall that's filled with infection, it can easily involve the next one over. Remember, the dermis down here is relatively thin. It's a lot of ground substance and some fibers. It's not packed tight like your epidermis. If that's the path of least resistance and the infection travels from pore to pore, then you can have these multi-pore involved nodules that are very persistent and very hard to treat. Topical treatments do a pretty poor job of taking care of them. You generally need some sort of medicine that either penetrates all the layers of your skin very well, like topical retinoids, certain topical antibiotics, or internal treatments, like if you take Accutane or minocycline as an antibiotic that can help control acne. This tends to be hereditary. It tends to be really severe and cause quite a bit of scarring. The other kinds can be bad and can be, a real plague for people. Cause a lot of unnecessary self-consciousness. It can cause scarring. It can cause uneven pigmentation. All the stuff that you don't want on your face. But they're not quite as severe as these cysts, because the cysts do persist so tenaciously, and they do tend to spread, and they tend to last deeper into adulthood than other kinds of acne. As you move through adulthood, your skin becomes thinner. You don't really notice this too much through your 20s and even oftentimes in your 30s or early 40s. Once you get past that a little bit, particularly in women after menopause, because you have such a dramatic change and not a petering out of hormones like men experience, you'll notice your skin becomes thinner, it becomes drier, and it becomes a little wrinklier and saggier. Reasons for this include that you retain less subcutaneous fat on your face. When you're younger, you retain more fat on your face, and that helps plump up your skin and helps prevent wrinkles to a point. If you pack on enough subcutaneous fat, if you're very overweight or obese, that can cause damage, that can cause impairment of proper oxygenation to your skin and things like that, and can prematurely age you. But in people of normal weight, normal health, normal diet, proper activity, all that good stuff, that subcutaneous fat that you have in your 20s and your teens and a little bit into your 30s helps keep a young, supple sort of a skin appearance. As you get older, your fibroblasts slow down. And they die. So when you're 20, you have more active fibroblasts and more of them in your dermis than you do when you're 50. The ones that you have when you're 50 aren't as productive, and there's just fewer of them. Because you have fewer fibroblasts, you're creating less collagen and elastin and things like that that keeps skin supple and bouncy and attached firmly to the substrate underneath. When you don't have as much attachment to the substrate underneath your skin can sag and wrinkle a little bit. This is the main reason why you have wrinkles, in fact. You also have slower cellular replacement after shedding, so your skin will become thinner, and it will simply just look a little bit different because the skin cells don't turn over quite as quickly. One of the benefits of using retinoids, retinol and retinoids, is that they increase cellular turnover. in people of all ages. So topical retinol or Accutane, internal pill taken retinol, can really go a long way towards clearing up cystic or nodular acne, because what it'll do is it will start your cells from turning over from the bottom up much, much, much faster than they would have otherwise. And this can basically help you, it is thought, it's not completely understood, but it is thought. It kind of helps you rebuild the basis of those hair follicles and restructure your pores so they're not as fragile as they were in the first place, and then that change can persist throughout the rest of your life. When you get older and your skin doesn't turn over, your skin cells don't turn over as quickly, those basal cells sort of reproduce or clone themselves a little more slowly, the retinol will help, or the retinoid that you can apply topically, anti-aging treatments that you get over the counter and stuff, can help speed up that change a little bit. So you end up with slightly thicker skin. The skin cells that you have are younger and fresher and a little bit healthier than they might have otherwise. It also helps encourage the activity of fibroblasts, so that the longer you use these retinoids, these topical retinoids, the slower it is for wrinkles and fine lines to develop. Now, none of these things are going to stop aging entirely, but it can help slow down the negative some of the things that we consider negative in aging skin. As you get older, though, your skin does kind of acclimate to it, so you'll need increasing dosages as you get older. Again, it doesn't stop things entirely, but it does help. And it does make you very, very sensitive to UV radiation, no matter when you take it in teenage years or when you're older and taking it as an anti-aging treatment. So even though it slows down some of the aging changes that you've accumulated by just sort of getting older, and that you've accumulated because you've been exposed to a lot of UV radiation in your life, which is going to kill skin cells, it's going to kill off fibroblasts, it's going to cause some genetic changes. It could make you more susceptible to those other UV changes, and potentially, if you don't take care to stay in the shade and wear enough sunscreen, you can use all the retinoids you want. If you still are exposed to too much UV radiation, it might not actually be worth anything. You also have lower melanocyte activity. This is what's going to cause sort of your skin becoming a little bit paler as you get older, and it causes your hair to turn gray. So the melanin that's laid down in the keratinocytes in your hair is what's giving your hair the color that it has. Melanocytes will die off, they'll become less productive as you get older, and eventually you're not going to lay down enough pigment to be seen as you get older. So your hair will become that sort of grayish color. And again, because your skin is damaged, or your skin is thinner and you have less melanocyte activity, you have less melanin in your skin, you become more sensitive to UV radiation as you get older. Hair follicles don't regenerate as readily, and they tend to not go back to the return to anagen phase after a certain point. So you'll also notice that your skin or that your hair becomes thinner. Your eyebrows become thinner and wispier in women, men and women, but in women you notice it more because they weren't very thick in the first place relative to men. Your hair overall can get thinner. You can lose some body hair. So I mentioned, you'll see a sudden growth of pubic hair and axillary hair when you go through puberty. That can peter out when you start to get quite a bit older, and so you'll typically never lose it, but it can become very, very thin. So since we were just talking about the problems from exposure to UV radiation with normal aging, let's talk about the sort of logical extension of what too much UV radiation can do in skin cancer. Skin cancer is typically caused by UV radiation exposure over time. How many sunburns have you had in your life? How tan have you become compared to your sort of baseline skin tone? How many hours have you spent out in the sun in a given patch of skin? You can get skin cancer for other reasons. Some people are genetically a little bit predisposed to it. Certain exposure to chemicals on your skin can increase your likelihood of developing skin cancer. But overwhelmingly, UV radiation is the #1 cause. The less melanin you have in your skin, the higher your skin cancer rates are. So people with very, very pale skin accumulate skin cancer at higher rates than people with darker skin. Now, this is kind of the sort of opposite of that is that people with less melanin have a higher skin cancer detection rate. So there's, systemic, frankly, systemic racist reasons why people with lighter colored skin might get better medical treatment. But it's also, frankly, just easier to see. So if you have a skin cancer changes tend to be darker in color than the skin around it. If your skin's baseline color is already pretty dark, it can be more difficult to detect that in somebody with darker skin than with lighter skin. So while people with lighter skin do develop skin cancer at higher rates than people with darker skin, they do tend to notice it earlier, they do tend to seek treatment earlier, and they do tend to have better outcomes than people with darker skin. Again, there's other much more complicated societal, systemic racist reasons why that play into these rates as well. But all other things being equal, it stands to reason that you might catch it a little sooner in lighter colored skin people. The reduced melanocyte concentration as you age then increases your risk of skin cancer compared to when you were younger. So even if you have very dark skin when you're in your teens, 20s, 30s, it's going to become lighter as you get older, and your risk of accumulating UV damage will get more as you get older. Remember that what melanin does is it absorbs UV radiation so that UV radiation cannot damage the nucleus. If you don't have a lot of melanin, you don't have a lot of that protection, and the DNA inside of your nucleus can be affected by those high energy UV radiation, those high energy UV rays. Generally what happens, and there's a lot of different mechanisms that can play into this, so don't take this as a blanket rule, but you have your DNA is exposed to UV radiation, and you end up with a breakage in your DNA, in the strands of your DNA. When your body goes into super Russian repair mode, it tends to make mistakes. And one of those mistakes is creation of what's called a thymine dimer. A thymine dimer is where you have two thymines next to each other, two T's next to each other, that end up being kind of accidentally bonded with the aid of this UV radiation by covalent bonds. When you have a covalent bond between those two nucleotides that you weren't supposed to have, it'll cause an extra kink in the overall shape of that DNA strand. It'll also mean that when you go to replicate each DNA strand, these two T's are going to be treated as if it was one T, and you're going to have a frame shift mutation down the rest of the line of DNA. When you have this frame shift mutation and you have your genetic code downstream pretty much completely different, more often than not, the cell will just die because the problem will not be conducive to its survival. It won't be able to carry out some basic functions. Sometimes it's benign where, yeah, you have this change, but it doesn't actually affect anything because all of your downstream proteins end up being coded the same. And sometimes it can cause a change that causes that cell to become cancerous. When you have an uncontrolled growth of these cells, you form what's called a tumor. When it grows out of control, it's referred to as a carcinoma, a cancerous tumor. Let's talk about the types of skin cancer that you could experience. The least malignant, the least likely to spread and break off into other places in your body, is basal cell carcinoma. You find this most often in places where you have a lot of UV exposure. Your head, your forehead, your hands. If you walk around all summer with bare feet or sandals, you'll find it quite a bit on your feet. People who drive, like truckers and stuff, with their left arm out the window will see basal cell carcinoma a lot in their left arm, not so much in their right arm. It directly correlates with the amount of UV exposure. Basal cell carcinoma is very common, particularly among people with very light skin coloration. It starts off as a smooth, shiny red bump like what you see here to the right, where it has this sort of raw, shiny, smooth appearance. And then in the middle, you end up with this ulceration. And compared to the darkness of that bloody, scabby-looking ulceration, the outside can look sort of pearly. Excuse me. Fortunately, because this is least malignant, all of your cancer cells tend to be localized in one small area. It doesn't tend to break off into your bloodstream and go other places. Simple removal usually suffices for treatment. What you'll do is you'll remove this cancerous tumor with a margin, and a margin is extra tissue around what you think is diseased. So if I were a surgeon, which I'm not, so I'm spitballing here, I would probably think that like this is all cancer cells. It looks red and angry and is definitely cancer. To make sure that I get any additional cancer cells that might have locally spread a little bit, what I'll do is I'll measure out 4 millimeters from the edge, and I will excise this way, this much tissue instead, including 4 millimeters deeper than I notice that this tissue goes, to make sure that I got all of it. This can be done fairly simply in any dermatologist's doctor's office. They'll do it under local anesthesia. They put a Band-Aid on it, you heal up, everything tends to be fine. I want to point out that all skin cancers can become malignant, particularly if you're severely immunosuppressed. Maybe you have advanced AIDS, maybe you're being treated for cancer and your immune system's really suppressed, whatever. These all can become malignant. So when I talk about the malignancy rates, I'm talking about in otherwise normal, healthy adults, okay? Typically in normal, healthy adults, if you find a basal cell carcinoma, it can be treated very quickly and easily in any old dermatologist's office. Squamous cell carcinoma is the second most common. Basal cell is the most common and least complicated. Squamous cell carcinoma is the second most common and second most complicated. This is also typically found in places with the most UV exposure, but it isn't quite as hard and fast as a rule of that as with basal cell carcinoma. So you do tend to find it a lot on your head, forehead, your hands, your left arm if you drive a lot, your feet, wherever sees a lot of sun. But you're a little more likely to find it other places too than basal cell. These are formed by the keratinocytes of the spinosum. So squamous cells come from your epidermis because those are all stratified squamous cells, right? And in particular, it's the cells of the keratinocytes of the spinosum that have become cancerous. What do you think were the type of cells that were becoming cancerous in basal cell carcinoma then? The basal cells, right? That very first layer of active, rapidly dividing skin cells, or one of those is what caused your basal cell carcinoma. In this case, it's formed by the keratinocytes of your spinosum. These grow quickly. They may become malignant, although not terrifically likely. More likely if you're immunosuppressed, less likely if you're otherwise relatively young and healthy. But it's possible. And these grow into a red, raw, but kind of scaly looking bump. Remember that these are growing out of keratinocytes, so you're going to have this extra sort of tough, flaky skin involvement. And these often hurt a little bit. Basal cell may or may not hurt. The ulcer in the middle might. You might mistake it for a pimple for quite some time, and only when it doesn't go away for a long time, you go to see a dermatologist. It probably hasn't spread though in the meantime, so it can be excised fairly quickly. This you'll notice as being weird much more quickly than basal cell. Because it's sore, it looks scaly and uglier than like a nasty pimple might, or a bug bite might, and it looks bad sort of right off the bat. Because it gets redder and angrier and more painful earlier on, you end up with reduced mortality and morbidity despite the fact that it can metastasize more easily than basal cell carcinoma. So even though squamous cell is more likely to spread, people tend to go to the doctor sooner and they get it taken care of sooner, and so it's less likely to become become malignant. So in practice, malignancy rates between squamous cell and basal cell are pretty comparable, but the difference is in that earlier treatment. If you have people who aren't getting treated, aren't going to the doctor, don't have access to quality medical care, squamous cell carcinoma sees greater rates of malignancy and overall mortality than basal cell. If/when you catch this in time, simple excision also does the trick. You do get local anesthesia. They cut with a bigger margin. So if with basal cell you would cut with 4, with squamous cell you would cut with 6 millimeters of margin. And again, this includes underneath, deep into the epidermis and dermis, 6 millimeter around the entire involvement of the tumor. And typically that's all that's required. You'll probably be monitored a little more closely after the fact by your dermatologist than with a basal cell carcinoma. All of these are going to require follow-up visits to the dermatologist just to make sure that it was properly taken care of. This is they're going to want to look at this a little longer because it is more likely to become malignant, but typically it's fine. Finally, we come to melanoma, and this is very serious. This is highly metastatic. It's not terrifically easily treatable. It's oftentimes resistant to existing chemotherapies. So you may get chemotherapy in response to melanoma, but it's less likely to work and less likely to work well. The metastasis can also be really varied and unpredictable. So it's hard to pick out which type of chemotherapy would be best for your type of melanoma, because one of the considerations that doctors take when picking out a chemotherapy regimen is, what is this cancer, not just what is this cancer and what is it doing now, but what is it likely to do and where is it likely to go, to metastasize to. And since melanoma is not very predictable in this way, or not as predictable as some other cancers, it can be harder to pick the appropriate chemotherapy. The overall incidence of melanoma is historically pretty low. Although it's always been much higher in people who see a lot of sun, like farmers, for example. It's growing across the board in response to the popularity of tanning, and particularly tanning salons where you can go and really tan all year long. That fortunately has been in younger people. Younger people now are less likely to go and tan, like go to tanning salons, than people my age. So it's predicted that melanoma rates will start to go down as people who are right now in their teens and 20s get older, but we haven't seen that trend yet. There is no common origin in the body. So the first two types of skin cancer are found overwhelmingly in places where your skin sees a lot of sun. Melanoma, you do see it more often there, but it's absolutely not restricted. You find melanomas all over your body. About a third of them come from pre-existing moles, whether they see the sun or not. The way to detect melanoma is with the ABCDE mnemonic. A melanoma, and this is how you can differentiate it from just like a freckle or a mole. They can change in appearance sometimes as you get older, particularly with major hormone changes, like during pregnancy, for example. So you're going to want to think about this ABCDE detection when you're trying to rule in or rule out melanoma in the face of a changing freckle or mole. Is it asymmetrical? So did it start off like this and now it's growing like this? Is the border irregular? Again, is it smooth border or does it have a lot of variation to the edging? Is the color changing and is the color uneven? So when you have a regular mole or a regular freckle that just sort of gets bigger, it will typically keep the same type of relatively homogeneous pigmentation. Now, it may not be perfectly homogeneous, but a melanoma will be quite heterogeneous. You can see like there's this big pale spot in the middle here, and there's some obvious much darker spots here. Here's a big dark spot and a lot of lighter spots. It'll be much more stark in melanoma. The diameter increases and it changes. It doesn't just sort of change a bit and then stop. It'll continue to change over time. Now, unfortunately, these changes are all harder to detect in people with lots of melanin because the changes are a spot turning darker brown on already dark brown skin. So that can just be harder to see in the first place. It also requires time. It may also be harder to see. Not necessarily, but maybe harder to see because of the location. So one of the elements of a melanoma is that it changes, and it keeps changing even after you think it might have stopped. So you might not notice it, first of all, because it's happening around a mole you already had, and it may or may not be someplace you see every day. Um, I have, for example, I have like a big mole in the middle of my back. That's a relatively high likelihood spot for developing melanoma, but I don't see the middle of my back basically ever. Um, I wouldn't notice that until somebody else pointed it out, or I happened to accidentally catch a glimpse of that in the mirror, at which point it might be quite advanced. A friend of mine, sorry, a friend of my sister-in-law's, um, she had a melanoma that was caught really early because she went swimming with my sister-in-law. My sister-in-law saw this in the middle of her back and said, "Oh, you got to go get that checked out." She would never have known that that was even there until it started causing her pain or other difficulty, because of the location of it. And even still, like let's say you do see it, again, one of the criteria is that it's changing over time. So you might notice it's a little different and go, huh, that mole got bigger. Weird. And then not think about it for 6 more weeks. And then go, did that get bigger? I don't know. I don't know. It was sort of bigger before, but I don't know that that's actually different. And then you wait another 6 more weeks, right? So you're waiting for these changes, or you're waiting for something to look really, really weird before you ever seek treatment. So it's been sitting there a while. These are all complicating factors to additional complicating factors for detecting and treating melanoma. Let's move on now to burns. I want to start this lecture, portion of the lecture off by mentioning that the following slides can be pretty hard to look at. We're going to look at first, second, and third degree burns. First degree burns we're used to seeing, that's basically a sunburn. Second degree is a little more gruesome. Third degree is pretty hard to look at. There's also going to be images of grafting. If that's something that you're sensitive to, which I have to admit for me, it's one of those pictures that always gives me the heebie-jeebies a little bit, you might want to just listen to the next slides after this rather than watching. So, to the original topic, burns. Burns are a destruction of the skin by basically anything. Heat, cold, electricity, chemicals, certain types of friction. We're not talking about a scrape so much as a persistent rubbing that causes irritation and sloughing off of the skin, or radiation like from the sun. How it's classified is by the depth of the burn as well as the extent of the burn across the body, and we use the rule of nines. So each region of your body is basically worth 9% plus your genitalia, which is by itself 1%. If a leg is burned, that's considered a 9% burn. If both legs are burned, that's considered a 18% burn. Each arm is worth 4.5. So if your arms are both burned but nowhere else, that's a 9% burn. If your arms and your torso are burned, that would be considered an 18% burn. You get the picture. Okay. So that's where you get the percentages. If somebody is suffering burns across X% of their body, that's how they calculate it. They also use it, classify it by the depth. So first, second, third degree imply depth of the burn, or indicate depth of the burn. Some areas, despite the classification otherwise, are just automatically considered to be more serious based on their location. This has to do with how that will scar, what type of pain the person's experiencing, and what the permanent effects of the burn might be, particularly when it comes to scarification. Places with thin skin are automatically considered more serious than they might otherwise, than if that same extent and depth of burn were found on a place with thicker skin. Genitalia is automatically considered really serious because of if there's scarring, you can have your urethra could get covered up on accident. You could lose sexual function. You could have, in men, so when you scar, you'll sometimes have like a pulling at the edges of the wound, which on a penis, on something like a flaccid, soft penis, can cause like a bending of the penis if your skin contracts. That can have really bad implications for sexual function and cause some serious pain. Your face is automatically considered way more serious, not just because of the cosmetic implications of it, but you have most of your major sensory organs there. Your face, your facial expressions are hugely important to communicating with other people. Your eyes are right there. They're really sensitive to burns, obviously. Your ears, if you have major scarring around your ears, that can have very serious implications for your hearing, your mouth, your lips, your tongue. That can impact your speech and your ability to eat very substantially, right? So your face is automatically considered more serious. Your hands and feet, because again, if you have scarification, or particularly around a joint, it can impact your your mobility or your ease of moving around those parts of your body. Plus, the skin tends to be pretty thin on your hands. If you have a burn around particularly an orifice, you need to consider that the burn goes deeper than you might otherwise see. So for example, if a person has facial burns, you're automatically thinking it's more serious. You might have, let's say, a 2nd-degree burn across 4.5% of your body with your face being burned, okay? You're going to treat it more seriously than you might otherwise a 2nd-degree burn over 4.5% of your body. If you have a 2nd-degree burn on your arm, that's bad, but you're only going to treat it so much. If it happens on your face, you're going to treat it more quickly, more aggressively, and you need to take into account that the inside of the person's mouth might also be burned. They might have burns down the length of their esophagus. If you're breathing in super hot air, if this person was in a fire, for example, breathing in super hot air can damage the mucosal lining of your trachea, of your esophagus, of the inside of your nose. These burns might end up being quite a bit more extensive than you can see, apparently. So I'm sure, as you can appreciate, burns can get pretty complicated pretty quick. There's partial thickness burns and there's full thickness burns. And partial thickness burns involve part of the layers of the skin. So not the whole way through the epidermis and dermis, but some portion thereof. Remember, when you're thinking about all of these burns, what role your skin has in the body. Your skin is a hugely important barrier, protecting your insides from outside infectious diseases, causing a barrier to prevent water loss from the inside, to prevent the moisture inside your body from just evaporating into the environment, preventing moisture from the environment from unproductively getting into your body. Your skin has fat right underneath it, right? And it is already pretty thick and tough and has like this oily barrier, and it helps keep a lot of heat inside your body. Losing skin in any major amount or losing functional skin by burns gets very, very serious very quickly. A partial thickness burn to the 1st degree is your most minor type of burn. Still extremely painful. Your nerve endings are in your epidermis, right? A lot of your nerve endings, these are going to hurt. Your skin is going to become very, very inflamed. That's going to put pressure down on those nerve endings and they're going to scream out. You have redness, you have swelling, you can be very sore, but it only involves your epidermis. So down here, this is a 1st degree burn. It only involves the epidermis. And so as your basal cells divide and fresh skin cells move closer up to the surface and you slough off the outermost layers of burned skin, the sunburn will go away if fairly uncomplicated. Keep it covered to prevent further sun damage. Keep it moisturized. You might want to take some pain relievers like Advil or something. Aloe can feel very nice because it has a cooling sensation and it's very moisturizing. You're going to mostly want to keep that area comfortable while your skin takes care of itself. You have very low risk of infection, very low risk of anything like an infection setting in. You're not going to lose a lot of moisture in that area. It'll take care of itself in about 5 to 10 days. 2nd degree burns involve the entire epidermis and part of the dermis. These are also going to be very, very painful because your nerve endings are going to survive to some degree. You're going to have a lot of inflammation in the skin around them, and when your skin inflames and pushes down on those nerve endings, you're going to scream out. Your nerve endings are going to scream out in pain. So you have all of the features of the 1st degree burns plus blistering. This is going down into the dermis, right? And what do you have a lot of in the dermis? What's the dermis made of? It's all connective tissue, right? So that's made of ground substance, which is really just like thickened up interstitial fluid, and fibers. So now you have this sort of separation, this injury to the skin as deep as you have this like extra fluidy kind of layer, and that fluid's not going to be very well contained in the dermis anymore. It's going to percolate up and cause these blisters. These blisters, if you leave them alone, they're never touched, you let them heal on their own, can be fine, frankly. It'll be very painful. It'll take 2 to 8 weeks for them to go down sometimes, depending on where it is, how bad it is, how severe it is, or how widespread it is. But they could be taken care of on their own. But because when they rupture and you now have exposure to deeper layers of skin, your risk of infection is higher. And the risk of an infection taking hold and spreading quickly is much higher than in first-degree burns, where it's that risk is very, very low. So during the time when you have a second-degree burn healing, you need to pay extra attention to hygiene to make sure you're keeping the area clean, but that you're also not breaking blisters unnecessarily. You need to be very, very gentle with the skin. They might scar when they heal. They may not scar when they heal. You'll have some variation with that. It depends on how deep those burns went and how big your blisters got. They may, if they scar up and they may heal with contractures. That's when your scar sort of pulls at the edges. I mentioned that in the last slide, and you create this tightening of skin. And if you have a flexible area, you might artificially bend it. Or if you have a place where you need to bend, you may not be able to straighten it. So look at your hand, for example, and look at your knuckles. Or look at the palm is sort of the easiest way to picture it. Look at your first knuckle there, like in the middle of your pointer finger, and picture if you had a burn, a second-degree burn there that's scarred, and your tissue, when it's scarred, shrunk a little. Now put your other hand there and pinch, and you're going to bend your finger. Now if that piece of skin is sort of shorter and tighter than the rest of the skin around it, you're not going to be able to straighten that finger anymore, right? That's going to have a big impact. Even though it's only a little bit of a change in your finger, that's going to have a big impact as to what you can do with that hand. And you're also not going to feel nearly as well on the place where you have that scar, so you're more likely to injure that region than other parts of your hand. So you have this impairment of mobility possibly, and you have an impairment of sensation, both of which are dangerous in these very sensitive parts of your body. So when you have a burn on your hands, if you have a second-degree burn on your chest, for example, you laid out in the sun too long, you fell asleep, you end up with a second-degree sunburn, you want to take super good care of it. You may or may not want to see the doctor. The doctor may or may not even do much about it once you get there, depending on what they see. If you got a second-degree burn on your hand, you want to go to the doctor. You want to make sure they look at it, and they're probably going to treat it relatively aggressively compared to other second-degree burns. And they're going to want to follow up with you too to check to see if scar tissue has formed, and if so, what the consequences are. People will need to go in and get plastic surgery sometimes to relax those scars so that you can retain or regain full mobility in places where you have excess scarification. These will typically heal on their own, though, provided you take gentle care of it for 2 to 8 weeks. Third-degree burns are called full-thickness burns. This is because it doesn't just involve the epidermis and some portion of the dermis, but it involves the whole layer, the whole thickness of the epidermis and dermis, and destroys it. This also, therefore, destroys everything that's embedded in there. Hair follicles, sweat glands, oil glands, nerve endings also get completely destroyed. This type of burn is painless on the area of the burn itself. Now the edges, like right around here, that's going to be angry and inflamed, the places that are adjacent to the burn are going to scream out in pain. It's going to be extremely unpleasant in those places. But this poor woman's skin, or what was her skin there, won't inherently hurt. This type of burn is not edemic. Edema is that fluid weepage that you get with like a second-degree burn. There's no edema here because frankly everything's destroyed. There's no place for fluid to weep out from anymore. But since you no longer have that waterproofing barrier between the inside of your body and the outside of your body, you're going to dehydrate very, very, very fast. your liquids from the inside of your body are simply going to evaporate into the environment very quickly. So one of the first things that you're going to be concerned about if you have a patient coming in with any amount of a full thickness burn is dehydration. These patients need to be very, very, very well hydrated. Depending on where their burn is and the extent of their burns, this might be an extremely difficult thing to do. You might not have good access to any of the more convenient places where you would put an IV in. You may need to pump in more IV fluids into the person's bloodstream than their bloodstream can reasonably handle, considering the extent of the burn. You might be evaporating it out too much. You might have too much inflammation involving the vasculature. This is a very hard thing to do. You also need to be extremely concerned about infection. Remember that your skin is a major antimicrobial barrier between the inside of your body and the outside of your body. Also, the microbiome on the outside of your skin, which doesn't exist anymore, would help keep other microbes in check. Also remember from lectures before that when the normal microbiome bacteria and fungi get into the body where they don't ordinarily live, they can take off and become infectious. Like they're totally fine when they sit on the surface of your skin and the surface of your skin is intact and everything is fine and normal, but if they get into the wrong place, they can cause major, major problems. For example, you have staph all over the outside of your skin as part of your normal microbiome, everybody's normal microbiome, and it doesn't cause you any problems. But if you get a nasty cut and that staph gets into the wound or is allowed to take hold once it gets into your wound because you didn't wash it quickly enough or thoroughly enough for how much got in, you can get a pretty major infection there, right? Normal staph that's all over your body all the time, every day, is now in the wrong place and now it's infectious. Now you have, with this burn, a huge open petri dish-like surface. It's warm, it's moist, it's got a lot of blood coming to it. There's all kinds of cellular debris from the destroyed tissue, and there's no microbes to outcompete it. This is like, you can't come up with a better breeding ground for bacteria than the surface of burned skin. So you need to be very, very conscientious about dehydration. The risk of infection is really severe. You're just as likely to get a bacterial infection as a fungal infection, but a fungal infection is very hard to treat. So you're extra concerned about fungal infections with burn patients. The walls of fungal cells are a lot more like our cells than bacterial cells versus our cells. So a lot of the treatments that we have for bacteria target the cells so that they rupture and they explode and they can no longer live. And that's great, because if bacterial cell walls and membranes are really different from our cell walls or cell membranes, you can target that and spare our cells. But fungal cell membranes are really similar to ours. So treatments that are designed to target fungi often take out a lot of our cells with it. And so you're going to want to reduce the dosage. And when you do that, you're less likely to kill the fungus. They also put out what's called hyphae, which are these long, thin sort of strands that really go deep into whatever they are, whatever they're growing on. And so surface treatments of fungus might not reach those places. So they tend to be very persistent. Thermoregulation is a very, very, very important thing with burn patients as well, third degree burn patients. They don't have that barrier of subcutaneous fat or skin to help keep them warm. You've lost a lot of blood and a lot of superficial blood vessels. So these patients can become overly cooled extremely quickly. If you go into a burn ward, or if you participate in burn surgery, the first most striking thing you notice the second you walk into that room is it's like a jungle. To keep these patients sufficiently warm all the time, because you can't put blankets on them, right? Their skin's gone. You can put bandages all around them and you can put a couple of blankets, but that's only going to do so much good and it's going to hurt. So you keep that room at 99 degrees, just like what their body temperature should be. You keep the humidity really, really, really high up in that room as well to help prevent dehydration. Remember, liquids will evaporate faster in a place with dry air because there's less humidity in the air to sort of counteract that pressure than in a humid room. So they're going to keep it super hot and super humid. That's going to go a long way towards preserving these patients' proper body temperature and keep them from dehydrating any faster than they're going to anyway. Unfortunately, it's also a beautiful breeding ground for bacteria even more. The reason that operating rooms and stuff are kept kind of cool is because it's a good sort of inexpensive, effective way of keeping microbial levels down. So it's a bit of a double-edged sword, but you have to keep it up. And finally, these patients' caloric requirements are through the roof high. Whenever you're healing, your caloric requirements go up. You need extra calories to heal wounds. You know, if you have a nasty cut, you're not going to need that many extra calories a day to build that little cut back. If you donate a pint of blood, that burns approximately an additional 600 calories over the next day or two. So making that extra blood volume back burns an extra like 600 calories or so. And think about how low impact donating a pint of blood is for most of us. Maybe you feel a little sleepy, a little achy, a little meh for a day. You're a little extra hungry, you're thirsty, but you bounce back from that no problem, right? You need an extra 600 calories to do that. After surgery, you need a lot of extra calories to make sure that those pretty extensive wounds heal up properly. Now think about if you have a full thickness burn, you have skin flat out across a broad surface of your body destroyed. Your body's going to try to heal that up. It's going to try to heal up the underlying tissue. Your body's going to want to crank up its metabolism to help compensate for the heat it's losing. A burn patient's caloric requirements can go from an average, like for me personally, if I'm super sedentary, so I don't need that many calories a day to maintain my weight. I need like 1,600 calories a day to maintain my weight. If I had a 3rd-degree burn like this poor woman in the picture, my caloric requirements in a day would go up to 15,000 or so sometimes, 15, 20,000 calories a day. It's extremely metabolically intensive to heal, especially with this type of wound, and it can sometimes be simply very hard to keep up with those kinds of caloric requirements. You can only consume so much so fast, so managing that can be very complicated. 1st-degree burns, 2nd-degree burns, taken care of properly, can heal on their own. 3rd-degree burns cannot. These require a skin graft. Healing takes a very long time and is usually incomplete even with grafting. We'll talk about grafting in the next slide. So grafting. The picture you see here is an example of an autograft being performed. You may have grafts that come from other species. You may get grafts that come from other people, ideally very close relatives so that the tissue matches. Or you may get grafts off of your own self. Ideally, you're going to get them off of your own self because you're not going to experience any tissue rejection. But that's not always possible. So you take what you can get. The first thing you do before you graft skin is that you debride away the eschar. Debriding is basically getting rid of. You're scraping it away, you're rubbing it away, you're mechanically getting rid of something. And eschar, and specifically debriding involves like dead, dying, infected, bad tissue somehow. And eschar is like charred, dead, post-infected tissue. Think eschar, like charred skin. So any of that skin that's on the surface that maybe was infected and now isn't, but it's just left over, any char, whatever, has to be scraped away. You need to get down to bleeding tissue. When you have scraped away enough surface tissue that the patient's skin bleeds, you know you now have healthy, healable tissue. So now you've scraped away skin basically until the person's bleeding. You will flood that surface with a broad strong antimicrobial agent. Again, this is now healthy tissue and it's exposed and there's a lot of blood and food and cellular debris around. Beautiful petri dish for things to grow, but you don't want anything to grow there because you want to graft there. And then you get your graft. It can, well, I didn't mention earlier, you can have a prosthetic graft, a xenograft, which would come from another species, usually pigs. Allograft comes from another person. An autograft comes from yourself. If you have a big burn on your arm, for example, but your legs are fine, they might graft off of your a patch of skin off of your leg and move it over onto your arm to patch that up. The healthy skin on your leg can be covered and grafted and taken care of itself later on. And what's cool is when you take that graft, you don't have to take as big of a section as you're going to need to cover. What you'll do is you'll scrape off this tissue so that you have, you know, like let's pretend this is a sheet of skin, and then you'll roll it through a mesher. And what that will do is it'll poke a bunch of holes into this so that that tissue, instead of just being one fairly rigid sheet, is now basically a mesh and it can stretch. So you can take a fairly small patch of skin, poke all these holes in it, and then stretch it out to cover a bigger area of skin so that when you take that initial graft, you're not taking any more than you absolutely have to. You're taking the smallest graft possible off of a different region of your skin. The graft might be sutured on, depends on the location, the shape, how big it is, things like that. But just as often as not, it's just held in place by lots and lots and lots and lots and lots of layers of breathable dressing. It'll be kept very moist. It will have usually some sort of, not like petroleum jelly, but other kinds of moistening, sort of a cream or a gel over the surface to prevent any extra liquid loss and to keep it moisturized. And lots and lots and to keep the dressing from sticking to it. And keep lots and lots and lots of tissue, layers of dressing over it to prevent any additional infection, to prevent any unnecessary moisture loss, and just to keep pressure on that graft, to keep it down up against the wound. Now you have this big, open, ugly wound, right, where you had the eschar debrided from, and you have this beautiful, healthy cross-hatching of skin that's going to be held on in place. Now the edges of the cross-hatching, those like raw edges of the skin you just grafted away and put on, can sort of heal up with the underlying skin or the underlying bleeding tissue. And so when your skin grows, instead of having to fill in this whole middle area just from the inside or from the outside in, if you have, and I'm just going to exaggerate the size of these holes, if you have surface area in all these little holes, you have less distance to go for healing tissue to infiltrate the dead area or the otherwise skinless area. It's a really sort of elegant, efficient way of doing these grafts. Pretty brilliant, I think. If you get a graft from anybody other than yourself, it might be rejected, so you always need to take that into consideration. If you can get a graft off of the patient themselves, you should get the graft off the patient themselves. Sometimes that's not possible. You're going to want to try then to go for an allograft or a prosthetic graft if possible. Xenografts can work very, very, very well, but they do have a slightly higher chance of rejection. And because the grafts usually come from pork, there's all sorts of people who simply won't get a xenograft. They'll reject it outright because it comes from pork. So you have to keep the other ones in mind at all times. Just like any other kind of surgical complication, the graft might become infected. And again, because you're doing this over a broad petri dish-like area, once an infection sets in, it tends to take off. It tends to be very hard to control, and it's very easily infected in the first place. Grafts often need to be redone. You will oftentimes need to graft over and over and over to completely fill that space because your graft isn't going to heal the full way up each time. There's simply going to be too much involvement to do in one shot. So these patients often need to get pulled into surgery over and over and over and over again to properly graft the area. Anytime you're doing this, you're going to expose bleeding tissue. You increase the patient's risk of infection. You're doing the surgery in a super hot, humid room because they can't thermoregulate. So their chance of infection is even higher. Every time you intubate a patient, there's a risk. Every time you anesthetize a patient, it's a risk. These are very complicated surgeries, and there's not, relative to other types of injuries, these are not, there's not nearly as many places in the country that can handle these types of patients with extensive third-degree burns as a lot of other injuries. You need a very specialized, dedicated space, set of personnel, set of instrumentation to be able to properly help these patients. The hospital that I used to scrub at when I was doing my scrub tech rotations, the Harborview Medical Center in Seattle pioneered some of these grafting and infection control procedures and burn healing procedures. So back when, in like the 70s, if you got a third-degree burn, you were just toast. Like if it was at all extensive, they would do what they could, but you just sort of assumed they were going to die. Harborview was a major hospital involved in figuring out how to graft these patients properly. They figured out how that you should keep the temperature really high. They figured out the likelihood of fungal infections and how to control those and how to properly hydrate patients. And so getting a third-degree burn over a lot of your body is still a very, very, very serious problem, still very often totally lethal. But it's gone from being a death sentence 40 or 50 years ago to, maybe having a real fighting chance these days. It's still not great if you have major third-degree burns, but it's better than not. Interestingly, the graft may or may not retain the properties from the harvested area. So let's say you have a big third-degree burn on your abdomen or on your side. Let's say on your side. Most of us, men or women, don't have a ton of hair on the side of their abdomen, right? And you get a graft from the person's thigh. Thighs are hairy, right? If you take that transplanted tissue from your thigh and transplant it onto your side, you might have a patch of hairy skin on your side now. If you get skin from a person with different pigmentation than you, or a part of your body that's pigmented a little differently than where you're grafting it to, you might have a permanently darker or lighter spot there. These traits may or may not be retained. There is, I want to point out, there is such a thing as a fourth-degree burn. This is almost exclusively lethal, and that's when you go into tissue deeper than skin. You start to burn muscle, you start to burn down to bone. Those types of burns aren't really a good thing to go over in an integumentary system lecture because they involve so much more than that. I just simply wanted to make you aware that those do exist.